This takes us to part 2 of 2 for the respiratory system. The respiratory rate, or rate of respiration, is the total number of breaths each minute. In our brainstem, there are collections of soma, which are nerve cell bodies, within the medulla oblongata, including the dorsal respiratory group, which helps provide a constant rhythm for breathing and stimulates the external intercostals and diaphragm. There's also a group of neurons and their cell bodies that make up the ventral respiratory group, which helps for forced breathing and stimulates accessory muscles. Within the pons, we have the pontine respiratory group, which include the apneustic center, which will regulate the depth of inspiration, and the pneumotaxic center, which inhibits the dorsal respiratory group to help control the rate of breathing. There are other factors that can affect the rate and depth of respiration. Systemic stimuli, if increased, will increase respiration in a positive feedback relationship. We have chemoreceptors that can respond to increasing levels of carbon dioxide and hydrogen ions. These chemoreceptors are located in the brain and brainstem, and we also have peripherally located chemoreceptors in the carotid artery as well as in the aortic arch. The hypothalamus and limbic system can also affect rate and depth of respiration, as an individual may respond to pain, emotions, or there may be an increase or decrease in temperature. Taking a deeper dive into respiration means understanding gas exchange, gas laws, and air composition. Partial pressure is the pressure exerted by a single type of gas in a mixture. Total pressure is the sum of all partial pressures. Dalton's law tells us that each gas in a mixture exerts its own pressure. The total pressure is the sum of all the partial pressures. Gas moves from higher pressure to lower pressure. The steeper the gradient, the faster the movement. Henry's law tells us that the concentration of gas in a liquid is directly proportional to the solubility and partial pressure of the gas. Alveolar air has a greater amount of water vapor and carbon dioxide, but less oxygen than atmospheric air. When partial pressures of oxygen and carbon dioxide change, diffusion across the respiratory membrane is affected. Oxygen enters and carbon dioxide leaves more quickly. Ventilation is the movement of air in and out of the lungs. Perfusion is the flow of blood in pulmonary capillaries. Ventilation and perfusion must be balanced for gas exchange to be efficient. The total matching of blood flow with ventilation is ventilation-perfusion coupling. In case of imbalance, the body can actually redirect blood flow to alveoli that are receiving sufficient ventilation. External respiration, the exchange of gas in the lungs, occurs as a function of partial pressure differences in oxygen and carbon dioxide between the alveoli and blood in pulmonary capillaries. Oxygen solubility is low, but the difference in partial pressures is drastic, about 64 millimeters of mercury. Because there's a strong gradient, that means there's going to be a rapid diffusion across the respiratory membrane. Carbon dioxide gradients are not as drastic, but the solubility for carbon dioxide is higher, so relative concentrations of each are relatively comparable. When it comes to internal respiration, now we're looking at gas exchange at the level of body tissues. Partial pressure gradients are opposite those of the respiratory membrane. Partial pressure of oxygen is low in tissues due to cellular respiration. In other words, the cells are using the oxygen, so the partial pressure of oxygen within the cells is not as high, it's relatively low. High oxygen pressure in blood causes oxygen to dissociate from hemoglobin readily, and from there it can diffuse into the cells. Cellular respiration produces carbon dioxide, so the partial pressure of carbon dioxide is higher in tissues than it is in blood. That causes it to diffuse readily from cells back into the blood. If you've ever heard of hyperbaric treatments, those are treatments that actually use pressure in different mixtures of gases from medical treatments. Hyperbaric treatments are often used to help heal wounds and grafts. They also help fight anaerobic bacterial infections. Anaerobic bacteria do not like oxygen. They can also be used in cases of carbon monoxide poisoning. Because oxygen is not very soluble in liquids, and blood is not an exception to this rule, only about 1.5% of oxygen is dissolved and carried in body fluids. Most of the oxygen in our body is bound to hemoglobin to be transported. Heme is the iron-containing portion, and it's what binds the oxygen. Oxyhemoglobin is simply hemoglobin with oxygen bound to it. Once one oxygen molecule has bound to hemoglobin, it increases the affinity of other oxygen molecules to bind with the hemoglobin. If you look at this picture on this slide, you'll notice that there are 4 molecules bound to hemoglobin because hemoglobin is a quaternary structure protein that has 4 subunits, each one containing a heme unit, so we can transport 4 molecules of oxygen on one hemoglobin molecule. And again, once one oxygen molecule binds, that increases the affinity for others to bind with that hemoglobin. Saturation is a measure of the percentage of heme units containing bound oxygen. When oxygen binds to hemoglobin, we say that it is associated with the hemoglobin. When the bond between oxygen and hemoglobin is broken, we say that it is now dissociated with the hemoglobin. And there is an oxygen hemoglobin dissociation curve, which is a graph that describes the relationship of partial pressure to the binding of oxygen to heme and its dissociation. The more oxygen that's bound to hemoglobin, the greater the affinity is for oxygen to bind to hemoglobin. And partial pressures are directly proportional to that heme oxygen binding. Temperature and pH can also have an effect on oxygen hemoglobin dissociation. Some tissues in the body have higher metabolic rates than others, causing a drop in partial pressure of oxygen. As more oxygen is needed by our cells, more is dissociated from the hemoglobin. Some oxygen, however, remains bound to hemoglobin and erythrocytes in venous blood, creating an oxygen reserve. When we look at the effects of pH on oxygen dissociation from hemoglobin, we can see that a lower pH is going to cause oxygen to be dissociated from the hemoglobin, whereas a higher pH, more alkalinity, would inhibit that dissociation of oxygen from hemoglobin. Metabolic byproducts such as lactic acid, carbonic acid, carbon dioxide can all work to decrease blood pH. So if someone is exercising a lot, that person is going to be creating more carbon dioxide as a metabolic byproduct, as well as lactic acid and carbonic acid. And so that means that the body's cells are using oxygen, creating carbon dioxide. Therefore, as the cells use up oxygen, more oxygen will dissociate from the hemoglobin to go into the cells. And so on this chart again, you can see that if there is an increased affinity for oxygen, then that curve shifts for the left. That means our cells aren't using oxygen as much if the curve shifts to the left. And you can see it's going to include a lower level of carbon dioxide, a higher pH, lower temperature. So if oxygen is bound to or associated with hemoglobin, the dissociation curve shifts to the left. If we're using oxygen, if our body cells are using oxygen, producing carbon dioxide as a byproduct, carbon dioxide is acidic, we've got more lactic acid, the pH goes down with increased levels of acidity, and body temperature rises. So that means we're going to have a reduced affinity for oxygen to bind to hemoglobin. So a right shift means I'm doing it backwards for what you're watching. A right shift, there you go, that's your right. Left shift, right shift. A right shift means that there's reduced affinity for oxygen to bind with hemoglobin, and that oxygen will dissociate from the hemoglobin when we shift to the right on the dissociation curve. Now, a fetus is going to be dependent on its mother for oxygen, even though it has its own red blood cells. Gas exchange for a fetus occurs at a structure known as the chorion, and that separates maternal blood from the umbilical cord and fetal blood. So fetal and maternal blood do not mix. Fetal hemoglobin has a higher affinity for oxygen to make up for the lower partial pressure of oxygen at the placenta. However, once born, respiratory rates are fastest in newborns. Why do you think that is? Next, we'll take a look at how carbon dioxide is transported in the blood. Carbon dioxide is transported in three ways. About 7 to 10% of the carbon dioxide in your body is actually going to be transported in blood plasma. So it can actually dissolve. 7 to 10% of that will dissolve in blood plasma. About 70% will be transported as bicarbonate ions or carbonic acid, which will also be dissolved in blood plasma. And then red blood cells are capable of transporting the remaining approximately 20% of carbon dioxide. If you remember, in the past I've said that hemoglobin can transport oxygen and carbon dioxide. Carbon dioxide transport is closely linked with a system known as the bicarbonate buffer system. Throughout our body, we have different chemicals that can act as buffers, making strong acids weak or strong bases weak, so that we can maintain a relatively stable level of pH throughout our different body tissues. And we already know that most of the carbon dioxide in our bloodstream is going to be transported as dissolved bicarbonate ions. And what happens is when we have carbon dioxide and water, those two can join together to form carbonic acid, which then will dissociate into hydrogen ions and bicarbonate ions, which can further dissociate into hydrogen ions and carbonate ions, depending on where the pH level is. If we need a lower pH, we are going to dissociate and allow for more free hydrogen ions. If we don't need that many, then they'll stay associated. So basically, as bicarbonate builds up in red blood cells, because this is happening in the red blood cells, it's going to move down its concentration gradient in exchange for a chloride ion. So as bicarbonate builds up in the erythrocyte, remember that the bicarbonate is going to be traveling dissolved in plasma. And so in order to keep electrical ions balanced within that erythrocyte, when bicarbonate ions are built up inside the erythrocyte, a negative chloride ion will come into the erythrocyte to balance it in terms of its electrical charges. And that exchange of chloride for bicarbonate is what we refer to as a chloride shift. And that's all occurring to help balance the electricity within the erythrocyte. Now, again, this is a reaction that's taking place in blood near our body's cells and tissues that are using up oxygen and creating carbon dioxide as a reaction, as a byproduct. This whole reaction actually gets reversed when the blood gets to pulmonary capillaries. When oxygen is bound to hemoglobin, we call it oxyhemoglobin. When carbon dioxide is bound to hemoglobin, we call it carbaminohemoglobin. And remember that about 20% of carbon dioxide is bound to hemoglobin to be transported to the lungs. The binding and dissociation of carbon dioxide to hemoglobin is dependent on partial pressures. Oxygen saturation to hemoglobin affects the ability of carbon dioxide to bind to hemoglobin. And so the Haldane effect is an effect that states that hemoglobin that's saturated with oxygen has a lower affinity for carbon dioxide. And that makes sense. If we've got a hemoglobin that's full of oxygen, well, where's the space for the carbon dioxide? It just really doesn't exist. Now, the Bohr effect states that an increase in carbon dioxide and a decrease in pH, so that means levels are becoming more acidic, will lower hemoglobin's affinity for oxygen, causing its release. So we know that when there's a decrease in pH, that means that oxygen will dissociate from hemoglobin. It also allows for carbon dioxide to bind to the hemoglobin, because we use oxygen, we create carbon dioxide. And there's also a molecule called 2,3-diphosphoglycerate, and you'll see that in this dissociation curve, it helps to shift the curve to the right, when its concentration increases, and it shifts to the left when its concentration decreases. So an increase in this molecule enhances oxygen release to the tissues by decreasing hemoglobin's affinity for oxygen. So it actually competes with hemoglobin and causes hemoglobin to say, yeah, I don't need oxygen. So it causes hemoglobin to get rid of oxygen. And that shift is often seen in physiological conditions, like an individual going up into a higher altitude, or somebody who has chronic anemia where oxygen delivery is really, really necessary for that individual. So 2,3-diphosphoglycerate can also affect how oxygen binds with hemoglobin, again, enhancing its release from hemoglobin to body tissues. High altitudes can affect respiratory function. An increase in altitude is going to result in being in an environment with decreased atmospheric pressure. So the proportion of oxygen is usually the same, but partial pressures decrease with altitude. And hemoglobin saturation tends to be lower at higher altitudes compared to sea level. And the body's mechanisms are going to be needed to ensure that our tissues get enough oxygen. So at sea level, hemoglobin saturation is actually higher, but fewer oxygen molecules are actually going to be released into the tissues for the cells to use. At higher altitudes, more of that 2,3 bisphosphoglycerate or diphosphoglycerate is going to be a molecule that helps regulate the release of oxygen from hemoglobin in our erythrocytes so that more oxygen gets released from the hemoglobin so our cells can use that. I previously mentioned that eupnea is that state of quiet normal breathing, and hyperpnea is a state of forced breathing where we see an increased depth and rate of ventilation to meet an increased demand for oxygen. This can occur as the result of respiratory or digestive diseases, exercise, high altitude, cold temperatures, or fever. Hyperpnea does not alter blood gas levels. It only meets the increased demands for oxygen. Hyperventilation is increased ventilation independent of cellular needs. It leads to low levels of carbon dioxide and alkalinity. When we look at the embryonic development of the respiratory system, you can see how the conducting zone develops first with bronchi and bronchioles and terminal bronchioles, and then there's a transition to respiratory bronchioles, alveolar ducts, and alveolar sacs that are last to develop. Respiratory distress syndrome is a syndrome that's primarily in premature infants due to insufficient production of surfactant. And that can lead to dyspnea, which is abnormal or painful breathing, and poor gas exchange, where the infant is not getting enough oxygen and has high levels of carbon dioxide. This can lead to other serious disorders, including septicemia or pulmonary hemorrhage, and treatment can include resuscitation, intubation, or the use of a CPAP along with pulmonary surfactant administration to keep the alveoli open. Emphysema is a type of chronic lung disease that's characterized by the destruction of the air sacs or alveoli in the lungs so that air is not able to be expelled. And damage leads to a decrease in total lung surface area, making it difficult for the lungs to take in oxygen and release carbon dioxide. On an X-ray, emphysema causes the lungs to appear hyperinflated and barrel-shaped while the diaphragm flattens. Usually the patient presents with a barrel chest. This also causes a decrease in the ability of the alveoli to come back to their normal size and shape because it destroys the elastic fibers as air is brought in, but it can't get out. So that's why that hyperinflation occurs.